Alrighty, everyone. Thank you so much for joining us for our educational webinar on cubital tunnel syndrome. Tonight's speaker is Dr. Desmond Stutzman, orthopedic hand and elbow surgeon at OrthoNeuro. Dr. Stutzman is a board-certified orthopedic surgeon specializing in hand and elbow surgery. He has expertise in fractures, carpal tunnel syndrome, wrist and elbow reconstruction, as well as arthritis, tendon, and ligament injuries from fingertip to elbow. Dr. Stutzman will answer questions following his presentation. Please type your questions into the Q&A below at the bottom of your screen. Dr. Stutzman, take it away.
Thank you very much. Well, good evening, everybody, and hope you're having a good evening. Oh, did I share it?
It doesn't look like it. It's the green bottom at the green button at the bottom of your screen again.
Why is that still showing up? How we doing there?
Do
you have it?
I don't see it. It doesn't look like you've been sharing your screen yet.
Oh, come on here.
There we go. I can see it now.
Finally, sorry about that.
It's all good.
All right. Again, I'm Desmond Stutzman. I am hand and elbow surgeon for OrthoNeuro, and we're going to talk about cubital tunnel syndrome. And I was happy to see that the topic kind of covered, why do I have numbness in my small and ring fingers, and or why does my hand feel weak and clumsy? I think those are two of the really kind of important points that you would kind of list as the title of this talk, because this is what most patients will show up with numbness and tingling in the ring and small fingers, or sometimes when it gets severe, they'll have this clumsy hand that feels weak and they can't grip or do anything with. So we're going to cover the where, the what, and the why of cubital tunnel syndrome. We'll go through some anatomy. I'm not going to give much, and then the pathophysiology, why, more of why we get it. Symptoms that you'll see, the diagnosis that we use, the diagnosis entities that we use, and then we'll go over the treatment and, of course, the questions and answering. So the where, the what of cubital tunnel syndrome. Obviously, the cubital tunnel region, the term cubital comes from the Latin cubitum, meaning elbow. And then you have the cubital tunnel region, which this is basically the defining area of where the nerve gets pinched. It's behind the elbow, and I've got a picture here in just a bit. And then when we talk about putting it all together, the cubital tunnel syndrome, a compressive neuropathy that affects the ulnar nerve as it passes behind the elbow. So first and foremost, here's the forearm. I've drawn a circle right around what's called the medial epicondyle, and that is the prominence that you feel on the inside of your elbow. Now, on the picture to the right, I've drawn exactly where the ulnar nerve passes through the cubital tunnel region. So this is where the term comes from, cubital tunnel syndrome. It's this exact area where the ulnar nerve, the nerve that gives you sensation to your ring and small fingers, this is exactly where it gets pinched. And we'll cover kind of why that happens. So we'll get back to a compressive neuropathy or pinched nerve. We use this term neuropathy all the time, and there's several different types of neuropathies. There's a metabolic, there's idiopathic, but we're going to really focus on the compressive neuropathies. That's the pinched nerve. That's the pressure that ultimately affects the blood supply of a nerve. And so when we get numbness and tingling in our fingers for whatever reason, actually what's happening is the nerve that gives that sensation to that area has been compromised enough that the blood flow stopped through that nerve. And that's when you get this kind of numbness and tingling that you experience. And so the function of the nerve is disrupted. And so it can either be an acute compression, trauma. I mean, if you've hit your funny bone, you've hit your ulnar nerve in the cubital tunnel region. And that's what gives you the zings down your hand. The cubital tunnel syndrome itself is more of a slow progression. It is a complex change that happens with the nerve. And so as we'll cover this over and over again about how it happens, it is a very complex progress of symptoms and changes to the nerve that happen over time. So as I promised, a little bit of the anatomy here. The nerve comes from the eighth cervical nerve and the first thoracic nerve. It's a combination of those two nerves that come out of your neck. It travels really in the kind of the back side of your arm, your upper arm. And then again, as we noted, it travels through that cubital tunnel region just behind that medial epicondyle, or that bump on the inside of your elbow, and then travels underneath some muscles into your hand. Now, I put the hand to the far right to kind of give you a really good reason why patients feel numbness in their small finger and then just part of their ring finger. If patients really pay attention when they come in, they'll say, boy, I've got numbness in my small finger, but you know what? My ring finger appears to be all right, but maybe on this side, it's a little bit, deficient. And that's because the nerve, as it splits towards the fingers to give innervation to those fingers, there's only part or only half of the ring finger that's getting innervated. The other part is from what's called the median nerve, and that's the nerve that goes through the carpal tunnel region. And so patients obviously that have carpal tunnel syndrome will have numbness in the thumb, the index finger, the middle finger, and then that one part of the ring finger. But again, we're focusing on the ulnar nerve, and that's the nerve that obviously just gives the sensation to the ulnar, or the ulnar side of the ring finger, or the small finger side of the ring finger. Now, the motor part of this nerve, so this nerve is made up of both sensory parts and motor parts. The motor parts of the ulnar nerve really do a lot for the hand. And that's why when patients have this cubital tunnel syndrome, or the ulnar nerve compression, they really have problems with function in their hand, because the ulnar nerve really does a lot of the intricate muscles in your hand, and it gives you the fine dexterity of the hand. And so the majority of the muscles that you use to spread your fingers apart or cross your fingers, or use your thumb to kind of pinch in, those are all muscles that are innervated by the ulnar nerve. And so when the ulnar nerve goes through a lot of dysfunction, you can see what happens. So as we're looking at the screen, the hand on the left obviously is normal, and the hand on the right side where the arrows are pointing, it's pointing out very specific areas of where the muscle has been lost, because in this patient, she had a very profound ulnar nerve deficit, or just long-standing cubital tunnel syndrome that was untreated, and the muscles have just atrophied away. And so you see that that area in the web of her thumb that just has lost. You can actually see the metacarpals, or the tendons, a little bit more pronounced, because those muscles that are in between the bones, those are the muscles that are innervated by the ulnar nerve. And so it's very important. This nerve is crucial to the hand, more so than even the nerve that goes through the carpal tunnel region. And so that's why cubital tunnel syndrome packs a little bit more of a punch when it really comes to the function of the hand, even though the sensation is only on the small and ring fingers. So why do we get it? Well, as we talked about before, this problem starts with increased pressure on the nerve. And so there are different reasons why different areas of our bodies where these nerves get in trouble. And so probably the clear-cut point is just direct compression. And so how many times do you sit at a desk, at a chair, with the armrest, in your car, your elbow's bent, and maybe it's just bent enough that it's putting pressure on the nerve with whatever you're contacting. And so that increases the pressure on the nerve. The very bottom depiction, the anatomy description here, it's a picture of the elbow in a extended position on the left-hand side. The yellow structure is the nerve, and you can see the nerve as it enters the cubital tunnel region, kind of as it goes from left to right. Now, the picture, the B picture, is showing what happens when we bend our elbows. And so when we bend our elbows, the pressure on that nerve is almost elevated sixfold. The volume of the cubital tunnel region is decreased by 55%. And so if your elbow is flexed for long periods of time, you're going to put enough pressure on the nerve to stop the blood flow. And so this becomes an important point, especially when we sleep. How many times do you wake up with your arms curled up, or maybe you, when you do go to sleep, you like to be in a curled position? The problem with this position is the fact that the nerve is being pinched, and through the course of the night, before your bodies can wake you up, the nerve has already gone through changes that may have damaged the nerve. And so a lot of us believe that cubital tunnel syndrome actually starts with behaviors as far as our sleeping patterns or our sleeping behavior and how we kind of bend our elbows. And so with the elbows bent at night, you increase the pressure, stops the blood flow, the nerve kind of gets shocked, you get waked up or awakened, and you feel the numbness and tingling, and you kind of change positions, and then all of a sudden the numbness and tingling goes away, but the nerve has kind of been injured, so to speak. And so then that may carry over, if you've done that for long periods of time, it may even carry over to you with a position that you just get in briefly during the day, and it increases the pressure, and the nerve then kind of reacts very quickly, and then you get numbness and tingling. And that's how a lot of patients, boy, I don't know what's happened. All of a sudden, I've just started getting numbness and tingling in my hand. And that's how we see this progress through time. There's also other reasons, obviously. The picture, the normal picture of the elbow is normal in the very top left picture. On the right, you see that with spurs and arthritis, you can get kind of impingement. So the groove on the left X-ray, on the right side of that X-ray, you can kind of see it's hollowed out. That's right where your nerve goes. That's right where the ulnar nerve goes. On the other side, you can see that there is actually some spurring. And then, of course, fractures can be a problem as well. We haven't talked much about the subluxation, and the subluxation is actually, when you bend your elbow, that the nerve gets pressured and sometimes can slide over that medial epicondyle, that circle that I drew on that very first picture, and that can cause trauma to the nerve. We know that there's reasons we'll never know why patients get cubital tunnel syndrome, and then we always have to think about metabolic problems when we're looking at patients with nerve compression, hypothyroidism, hyperthyroidism, diabetes. Those are all things that kind of, again, can coexist and potentiate the possibility of a compression neuropathy or cubital tunnel syndrome. So what are the symptoms? What are going to be the symptoms that you present with? Initially, it's numbness and tingling, but I mean, everybody has presented in every different way that I've experienced. Some patients have numbness and tingling. Some patients will tell me that their elbow just aches and just kind of aches on the middle or the medial side or the inside of the elbow, and they don't have any reason why. They don't have any really tender areas, although if they get into that funny bone area, they immediately have some kind of striking pain. In other patients, it's more mysterious, and there are some patients that never experience any numbness or tingling, or don't think they have numbness and tingling, or for whatever reason, they have numbness and tingling in their entire hand and they can't really differentiate. And that's when the patients can kind of go on to having this nerve being compressed over time. And so with a lot of compression and no treatment, the patients can have the nerve actually go through changes where it becomes irreversibly damaged. If the nerve is getting starved of its blood supply over time, sooner or later, the nerve may become irreversibly damaged. And that's what we can kind of see in the patients where they've lost the muscle. And that's what you see in that top right picture. Again, the hand on the left has lost the muscle by the thumb. You can also see the tendons and bones a little bit more clearly. And so again, over time, if this isn't treated, appropriately, the nerve can undergo these changes. And so for some of these patients, that's a weak grip, that's a clumsy hand. They can't grab, they can't pinch, they can't turn their car on. They have to actually reach around with their other hand. And as we talked about, the aching pain on the inside of the elbow. But the number one probably symptom that I see are patients that present with the numbness and tingling, and that's usually the first sign. A lot of patients will give me the history that they've been awakened several times during the course of the night, because as you go through this process, your nerve becomes a little bit more sensitive. Now, we talked about there's changes in the nerve through time. And one of the big changes is that when the nerve starts to initially get irritated, the first thing it does is swell. And the cubital tunnel region is a defined space. It is a tunnel where that nerve passes through, and it doesn't allow for any swelling of the nerve. And so you see the cascade of events that can happen. The nerve gets irritated, it starts to swell, and then it starts to put pressure on itself even when the elbow is not bent. And so that's where we see this kind of elevation in pain and problems with patients, that they're having symptoms through the night, but then all of a sudden they get these symptoms during the day when they really haven't done much to irritate the nerve. And that's when a lot of patients present. So I think the one of the biggest keys to diagnosing this is when a patient comes in, gives me the history. And of course, the exam, there's very specific points in the exam that we utilize. There's essentially the funny bone test, if you will. It's basically tapping the nerve. Most everybody should not have a very sensitive nerve in that area, as it passes through the cubital tunnel region. But again, as we said, the more the nerve gets irritated, the more hypersensitive it becomes. And so tapping on this nerve will give you immediate shocks to the finger. And maybe even patients notice that they're setting their arm down on the table and they can't get a comfortable position because it always irritates the nerve. These are kind of common findings for patients. Now, one of the most objective tests that we have is called the electromyogram and the nerve conduction velocity test. These two tests are what you see happening on the right side. And unfortunately, it is a needle exam, but it usually isn't too bad. And the patients that come back from this test say it's a little bit irritating, but not too bad. Essentially what we do is that we map out distances and we put the needles into the arm, and then an electrical stimulus is put across the nerve, and the nerve picks up that stimulus and the impulse travels down to the end into the hand. And there's areas where we put the needles into muscles to see when those muscles respond to the initial stimulus. And so when you track that, we can keep track of the time that it takes for that to happen. If the nerve is becoming compressed, if it's becoming irritated, then that impulse will slow down. And obviously from all the nerve studies, we know what normal impulses should take to travel a certain distance. And so we mark out these specific distances and stimulate the nerve. And that way we can say how objective is the cubital tunnel syndrome, or how severe is the cubital tunnel syndrome. And so when we look at patients, we usually have it defining mild, moderate, and severe. Patients with mild, as we'll talk about later, are easier or can be treated more conservatively. The patients with moderate and severe, those are the patients that we start to worry about, because obviously there is a time limit, there's a time frame on cubital tunnel syndrome. If you wait too long to have this treated, you could have an irreversible change to the nerve. And that's what we're desperately trying to avoid. And even in today's day and age, with all the advances and all the talks about cubital tunnel syndrome and information, unfortunately, patients still show up and have irreversible changes even before I've seen them. And not all hope is lost. Obviously, treating them aggressively a lot of times can maybe reverse a little bit of the problem. Ultrasound is one avenue that's actually being increased in use. And the ultrasound is a very simple and quick way to look at the anatomy of the nerve. And a lot of times when the ultrasound has been performed, you can actually see an hourglass deformity of the nerve. And you can really map that out. And there's been some very good studies to show that we're getting better and better at this technique. And so for patients that have sometimes normal nerve studies, happens, even though it's one of the best tests that we have, patients with the electromyogram nerve conduction velocity test sometimes can have an electrodiagnostic cubital tunnel syndrome. And so it makes it very difficult. Patients come in and they have all the symptoms. You get a nerve study and the nerve study is normal, but the anatomy can really help us in this instance. And that's when the ultrasound comes in. And a lot of the complex cases, revision cases, patients that have had maybe trauma, scarring in the area, ultrasound is really big in regards to defining this. X-rays, as we pointed out before, just to ensure that we're not showing spurs or areas where the cubital tunnel region has been narrowed. And then MRI, again, in the more complex cases for those that may have had previous surgery in the area or trauma prior. And then the further metabolic workup. Obviously, we talked about the other problems that coexist with compression neuropathies, those problems like diabetes that make nerves more sensitive, essentially. So treatment, the non-operative. And so when we get a patient that has maybe some mild electrodiagnostic findings, they don't have numbness and tingling that's constant. These patients are ones that can be treated non-operatively. And so I've given kind of three quick areas: changing your behavior when you sleep, but maybe that doesn't always work because, as soon as I go to sleep and if I put myself into a position, I'm going to probably change as soon as I get more comfortable. And so the bottom picture shows one of the simplest things that we offer to patients or recommend to patients. Starting to have numbness and tingling in your fingers, maybe waking up at night when your arm's bent in a position, wrap a towel around your arm, tape it in that position, and it makes it so bulky that you can't bend the arm. There's more established braces, as you see on the far right, that basically just prevent the nerve from getting into that hyperflexed position. And these have been very effective. And if caught early enough, patients with maybe 3 to 4 months of the towel or the braces can ultimately change the outcome and may not need an operative procedure. And more so, I think, than carpal tunnel syndrome, patients with cubital tunnel syndrome, when treated appropriately, and if they're able to tolerate utilizing a brace at night or the towel. I mean, from my standpoint, I tell my patients to do these things, and I don't know if I would be able to withstand it because I probably wouldn't sleep. But more so than carpal tunnel syndrome, I do feel that these non-operative ways have been able to change patients to the point where surgery wasn't needed at all. We talk about the stretching exercises, nerve glides. It really just consists of staying active. And for a lot of patients, one of the primary questions to me is that, should I stop working out? Is working out irritating the nerve? And that could be the furthest thing from the truth. Now, if you're doing exercises where you're having your elbow flexed for long periods of time, I would say, no, I don't like that. But there's not too many exercises. Exercises are usually motion. Motion helps actually massage the nerve and move blood flow through the nerve. And that's what is very important. And so when we talk about the nerve glides or stretching exercises, it doesn't consist of anything else other than just good stretching for the upper extremity. That moves the nerves around. It keeps them, the blood flow, moving. And so a lot of times when you look at even patients that sit at a desk and maybe their elbow is not bent into a hyperflex position, maybe it's just kind of semi-bent. Well, if you're in that position for long periods of time, the nerve gets pressured in the same area over that time period. And so that pressure area can then start to increase as time goes by because the nerve gets in that position, it's not being moved around. And so even in patients that aren't bending that elbow, they can actually get some, injury to the nerve. And so life is motion. You've got to make sure that you take breaks, stretch the arms, move the arms around. That puts blood flow through the nerve and keeps the nerves healthy. So for surgical treatment, probably one of the most important things that I ask a patient is, how much numbness do you have? When patients describe their numbness and tingling as being constant, that's usually the worst prognostic indicator. That's telling us that your nerve has undergone compression enough that there are changes that are happening, and the lack of blood flow to the nerve for almost 24/7. And so that's when the nerves become or can become irreversibly damaged. And so persistent numbness and tingling, obviously the electrodiagnostic studies, as I talked about, the EMG and the nerve conduction velocity test, when those get to a moderate or severe, and they're in conjunction with patient symptoms. And so patients are saying, well, my numbness and tingling is almost constant, and they have a really severe finding on their nerve studies, then those are patients that are definitely indicated for surgery. Muscle weakness is almost a knee-jerk reaction to the surgery, because when you look at a nerve, the most sensitive part of a nerve is the sensory side. Those are the sides that if you would just put equal pressure on a nerve, the sensory side would be the side that would get dysfunction initially. The motor side is very hardy, and it can take a great deal of pressure before it starts to become compromised. And so that's why when patients tell me or show me that they're having muscle weakness, when we go through the testing, those patients, if they're showing signs, obviously, of cubital tunnel syndrome, those are the patients that are definitely indicated for surgery. Now, the surgery consists of releasing all the areas of compression, and it's I would say it's a textbook type procedure when you look at it. We know the very certain areas where the nerve becomes compromised. It's a small incision just on the inside of the elbow, just below that medial epicondyle region, right where the initial markings were that I had in that initial picture. And it's essentially just a dissection of decompressing the nerve. And so once we're done completely decompressing the nerve, we kind of take the arm through a range of motion and find the area where that nerve would reside in without having pressure. And sometimes it consists of taking some bone out of the area just to make the tunnel bigger. Sometimes it even consists of moving the nerve. If the nerve wants to be in a different location, that can be figured out once the nerve has been completely decompressed. And that's how we kind of proceed with the surgery itself. It's a 15-minute procedure, general anesthetic, and you wear a dressing for about 3 days after the surgery. And really, we want motion. After the surgery, the patients are encouraged to start moving the arm as much as they can, do as much as they can tolerate. Obviously, if they're having a great deal of difficulty or pain, we want them to back down. But for the most part, we want them to move because, again, we want that nerve to be getting kind of the blood flow through it. And also, we don't want the nerve to get scarred in, because anytime that you operate on a nerve in any area, motion is key, because the nerves will tend to get glued down or kind of stuck to other structures in that area. And that's the last thing that we want in regards to those surgeries. So the nerve recovers about an inch a month. And so with patients that have had some really severe cubital tunnel syndrome, it's very distressing, because we will perform the surgery. They'll come back into the office 2 weeks, maybe 4 weeks, maybe even 2 months. And if you look at the length of where the compression started from to the very tip of your finger, that's more than a foot in a lot of patients. And so when you get the recovery, so from where the nerve has been compressed the most to the area where it needs to regenerate to, a lot of times that process is about an inch a month. And so sometimes patients don't really recognize any recovery in their nerve until this nerve has gone through this process of recovery. Now, a lot of times it's quicker than an inch a month, but in the worst case scenarios, it can take almost a year before patients get these back. But it's not so much doom and gloom. It just gives us hope that the nerve's going to recover through that time period. I had some pictures of nerves, but I didn't know if anybody wanted to see that, so I skipped that. I'm happy to answer any questions that you have on the talk and any other questions that you want to pose.
Alrighty, it looks like we have a few questions. The first one is, what is the difference between carpal tunnel and cubital tunnel syndrome?
Well, just the different nerves. The problem is the same. Carpal tunnel syndrome's compressive neuropathy. That is, again, a pressure on the median nerve that gives you sensation to the thumb, index, and middle finger, where cubital tunnel syndrome is the ulnar nerve, and that happens at your elbow, and it gives you numbness to your small finger and your part of your ring finger.
All right. And then, is this an patient surgery?
Yes, outpatient procedure. We usually utilize a block in the arm, and so we can decrease the amount of anesthesia that the patients require. And it is, like I said, about a 15-minute procedure, but an outpatient procedure always.
Okay. And then the next question says, I have an office job. How long would I need to be off work?
Well, from the standpoint of returning to work, this is always one of the bigger questions, because in some patients we are, again, kind of removing some bone through that tunnel region, and so essentially the body feels as if there's a fracture, a broken bone. And so from the standpoint of, are you going to injure anything? From my standpoint, no. You can go back to work as long as you're not doing a heavy lifting, pushing, pulling, or in a job activity where you would have to defend yourself. You could go back to work very soon, as early as maybe 3 or 4 days. I would obviously count on the fact that pain control may be, in the first couple of days, may be difficult, but we've had patients go back to work, in an office setting, in an area where they're not doing much in the way of lifting, pushing, pulling. They've gone back as early as 3 to 4 days. We require that the dressing stays on for 3 days. And then after that 3 days, you can take the dressing off and use a small Band-Aid if you want, or a small wrap. But from the activity of driving and lifting, pushing, pulling, if you feel comfortable and it's not causing you a great deal of pain, we encourage it.
How long can I wait to have this fixed?
Well, and that's the very important part about this, is that the numbness and tingling. And so if you have a nerve study, and the nerve study shows that you're maybe in the moderate area and your numbness and tingling is not constant, then utilizing a splint at night, making sure that you are changing position at any point in time during the day if you're experiencing numbness and tingling, you can put this off, until you would start to see advancing symptoms. And so when I say advancing symptoms, a lot of times patients will come in to see me and they'll have numbness and tingling, and it's pretty consistent, not constant, but very consistent. Their nerve studies show that they have a moderate degree of compression through their nerve studies, but they just don't have the time. And so we're very, very clear with them. I check those patients back to make sure that they're not showing any signs of changes in their musculature. And as long as they're utilizing the splints at night and keeping the arm straight, and they're not going through the nights and having occurrences where they're waking up because of numbness and tingling, those patients can put this off, and they can delay it as long as their symptoms aren't advancing. When patients start to have breakthrough problems, so they're wearing their brace at night and they say, it still goes numb, or during the day, boy, it's going numb for most of the day. Or if there's any muscle weakness, you really can't delay, because then you're risking irreversible changes to the nerve. And once that happens, you're really doing the surgery just to prevent further loss. And so there's numerous patients that I've taken care of that, unfortunately, we've had to look at them at the time of their evaluation and tell them this probably isn't going to get better. The only reason that we're doing the procedure is to prevent further loss.
All right. Can the pain and numbness in my hand be from something other than cubital or carpal tunnel syndrome?
Oh, definitely. Yeah, obviously the nerve pain is just one component of pain into the hand. Now, numbness usually is nerve related. And so that when patients come in with problems with numbness and tingling, that usually is the first place that we're going to look at is at a nerve problem. Now, from a pain standpoint, you have so many complexities with the hand. There's so many moving parts, the tendons, the joints. There's so many other reasons for hand pain, just not nerve.
And it looks like that was our last question. Thank you so much, Dr. Stutzman, for your presentation. And thank you to everyone for participating in tonight's webinar. Our next webinar will be on November 3rd at 7 p.m. Dr. Dustin Reynolds, interventional pain management physician, will be speaking on non-surgical spine care. Look on our social media pages for additional information to come. And thank you all and good night.
Good night. Thanks.
Thank you.